Venous stent migration is a serious problem, potentially. We know about stents in the arterial system. Probably they don't even migrate, or when they migrate only like a couple of millimeters, and that doesn't have any detrimental effects. However, in the venous system, you have to realize, for example, you're stenting an iliac vein. And if the stent migrates from there, it moves through the inferior vena cava. And where does it end up? In the heart, or maybe in the pulmonary arteries if you're lucky, and if it's deployed nicely, maybe you can leave it alone. But if it ends up in the heart, then you have a very, very problematic situation, maybe even life-threatening. You have to realize that then maybe very acutely a cardiovascular surgeon needs to come. You need to crack open the chest, and that stands in no relation to the problems that you're actually trying to treat. You know, the venous problems are cumbersome, are not nice for the patients, but there's in no means venous problems or venous pathology is life-threatening or anything like that. So this complication, a stent migration, is in no way in relation to that potential life-threatening complication. Sizing is a really big issue, and you really need to be sure about the correct size of the stent. The other thing, that's why I said, you know, it's principally a physician's mistake, is that if you try to treat a lesion that's not really significant enough, then the stent is of course not helped by that lesion. So what do I mean with that? We know that 50% 50% stenosis in a vein is suggested to be significant. However, if you misdiagnose that and you're trying to treat something that's very fluctuating, maybe 40 or 30% of stenosis, and you place an adequate size stent in there, still it migrates away. It might migrate away because of the very smooth lining the endothelium and thereby create a migration. So those are the two possibilities, I think, mainly, and both principally caused by the physician. First of all, I think most lesions that are being treated at the moment are maternal lesions or compressions, NIVLs. And those lesions are relatively short. There's not, you know, the inner lining, the lumen is smooth, and there is a high potential risk, I think, of stent migration, a higher potential risk. And I know there are physicians that try to prevent that by placing a longer stent. Let's say if you place a stent of let's say 120 millimeters all the way through the confluence and down into the external iliac vein, then you might prevent stent migration. However, then you treated a long segment of a healthy vein. You don't want to do that. So we only want to treat that specific lesion, theoretically, right? So that's only like 2-3 centimeters. The problem is that we do not have a stent currently that you can place there with a, you know, I wouldn't do that with a good feeling of 4 centimeters, simply because of the risk of migration. So maternal, you need to think really hard about the stent that you use, and how far do you extend the stent down, sizing, etc., etc. That in contrast to stents placed in the post-thrombotic obstruction. Post-thrombotic obstructions are more rough, of course. They have there's a lot of trabeculations, fibrotic trabeculations. It's usually a very highly stenosed or occluded vessel, so there's a lot of outward force on that stent. So the stent is being held for sure, and even more so is because the lesions are way longer. So in most cases, we're talking about 15, 20, 25 centimeters, maybe all the way through the iliac tract. So stent migration in a post-thrombotic obstruction probably will not occur, but a maternar that is more likely. A maternar is a more likely lesion to to be careful with, or to, that stent migration might happen and therefore be careful with. Tips and tricks in the venous system and to prevent stent migration is not easy. There is a big issue in venous interventions. It gained enormous popularity over the last years. I think that's a great thing because it gets more attention and venous patients need to be treated, and they were undertreated for a very long time. But it also has a potential problem to that, and that means lesser experience. Because when we started out, there were high volume centers that did all the procedures in a certain region or country, and we have a lot of experience. Now, a lot of physicians start out with lesser experience, and that doesn't mean that they're doing it not correctly, but of course there's a lot to venous stenting and a lot of potential problems that might occur. For example, sizing that I just mentioned. And I think that if you want to talk about one tip or trick, then it has to be endovascular ultrasound for those physicians, maybe for all, but specifically for those with lesser experience, because IVUS is really going to help you with 100% certainty with the diameter, with the stent sizing, with the stent length, with the stent positioning, and thereby stent migration is definitely less likely to occur. So last issue that I really would like to place emphasis on is renal vein stenting. The renal vein is way shorter than the iliac tract. It is different orientated. It moves during respiration, and those issues really play a significant role in the risk of stent migration. So I myself, I am very conservative with renal vein stenting, and that would be something that I would like to advise the community to realize stent migration is an issue and take the indication conservatively.